Hi and welcome back to another video of Medic Notes. This video is on intracranial hemorrhage. Intracranial hemorrhage encompasses four broad types of hemorrhage: epidural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and intraparenchymal hemorrhage. The first two are called extra-axial hemorrhage, and the latter are intra-axial. Etiology: an epidural hematoma is arterial or venous in origin. The classical arterial epidural hematoma occurs after blunt trauma to the head, typically the temporal region. This type of bleeding may also occur after a penetrating head injury. Typically, a skull fracture with damage to the middle meningeal artery causes arterial bleeding into the potential epidural space. Although the middle meningeal artery is classically described, any meningeal artery can lead to arterial epidural hematoma. A venous epidural hematoma occurs after a skull fracture, and the venous bleeding from the skull fracture fills the epidural space. Venous epidural hematomas are common in pediatric patients. Next, subdural hemorrhage occurs when blood enters the subdural space, which is anatomically the arachnoid space. Commonly, subdural hemorrhage occurs after a vessel traversing between the brain and skull is stretched, broken, or torn and begins to bleed into the subdural space. These most commonly occur after a blunt head injury but may also occur after penetrating head injuries or spontaneously. Next, a subarachnoid hemorrhage refers to bleeding into the subarachnoid space. Subarachnoid hemorrhage is divided into traumatic versus non-traumatic subarachnoid hemorrhage. A second categorization divides subarachnoid hemorrhage into an aneurysmal and non-aneurysmal subarachnoid hemorrhage. Aneurysmal subarachnoid hemorrhage occurs after the rupture of a cerebral aneurysm. Non-aneurysmal subarachnoid hemorrhage is bleeding into the subarachnoid space without identifiable aneurysms. Lastly, intraparenchymal hemorrhage is bleeding into the brain parenchyma. A wide variety of reasons cause hemorrhage, including hypertension, arteriovenous malformation, amyloid angiopathy, aneurysm rupture, tumor, coagulopathy, infection, vasculitis, and trauma. For epidemiology, epidural hematomas are present in approximately 2% of head injury patients and account for 5% to 15% of fatal head injuries. Approximately 85% to 95% of epidural hematomas have an overlying skull fracture. The incidence of subdural hematoma is estimated to be between 5% and 25% of patients with a significant head injury. Subarachnoid hemorrhage accounts for approximately 5% of all strokes, whereas intraparenchymal hemorrhage accounts for 10% to 20% of all strokes. For clinical features, epidural hemorrhage. Patients with epidural hematoma report a history of a focal head injury, such as blunt trauma from a hammer or baseball bat or fall. The classic presentation of an epidural hematoma is a loss of consciousness after the injury, followed by a lucid interval, and then neurologic deterioration. This classic presentation occurs only in less than 20% of patients. Other common symptoms include severe headache, nausea, vomiting, lethargy, and seizure. Subdural hemorrhage. A history of either major or minor head injury can be found in cases of subdural hematoma. In older patients, a subdural hematoma can occur after trivial head injuries, including bumping of the head on a cabinet or running into a door or wall. An acute subdural can present with recent trauma, headache, nausea, vomiting, altered mental status, seizure, or lethargy. A chronic subdural hematoma can present with a headache, nausea, vomiting, confusion, decreased consciousness, lethargy, motor deficits, aphasia, seizure, or personality changes. A physical exam may demonstrate a focal motor deficit, neurologic deficits, lethargy, or altered consciousness. Subarachnoid hemorrhage. A thunderclap headache is the classic presentation of subarachnoid hemorrhage. Other symptoms include dizziness, nausea, vomiting, diplopia, seizures, loss of consciousness, or nuchal rigidity. Physical exam findings may include focal neurologic deficits, cranial nerve palsies, nuchal rigidity, or decreased or altered consciousness. Intraparenchymal hemorrhage. Non-traumatic intraparenchymal hemorrhages typically present with a history of sudden onset of stroke symptoms, including a headache, nausea, vomiting, focal neurologic deficits, lethargy, weakness, slurred speech, syncope, vertigo, or changes in sensation. The Glasgow Coma Scale, GCS, helps quickly rate the severity of a patient's neurologic injury. The three components of this score are eye-opening, best verbal response, and best motor response. TBI can be classified based on GCS as mild, moderate, and severe. Lab studies include full blood count, COG profile, and renal profile. For imaging, Non-contrast CT scan is the main modality. In epidural hemorrhage, if intracranial pressure increases, a Cushing response, which are hypertension, bradycardia, and bradypnea, may occur as compensation. The characteristic imaging finding is a hyperdense extra-axial lens-shaped opacity. In subdural hemorrhage, acute events are typically hyperdense, while a chronic subdural is hypodense. In subarachnoid hemorrhage, it is typically hyperdense on court. If the CT scan is negative and a strong suspicion of subarachnoid hemorrhage exists, a lumbar puncture should be considered. The LP results may show xanthochromia. In intraparenchymal hemorrhage, imaging will show hyperdensity within the parenchyma. Consider an MRI brain in some cases. For treatment, immediate neurosurgical consultation is recommended for all hemorrhages, but mainly if alarming signs such as airway compromise, respiratory failure, or hemodynamic instability exist. For epidural hemorrhage, definitive treatment is an evacuation of the hematoma and stopping the bleeding source. Some smaller epidural hematomas may be managed non-surgically and monitored for resolution. Conservative management is attempted if the patient satisfies all of the following criteria and has mild symptoms. Epidural hematoma volume of less than 30 milliliters. A clot diameter of less than 15 millimeters. Midline shift of less than 5 millimeters. GCS greater than 8 and, on physical examination, shows no focal neurological symptoms. For subdural hemorrhage, definitive treatment is an evacuation, but depending on the size and location, some subdural hematomas may be monitored for resolution. Non-surgical management options include repeat imaging to ensure subdural stability, anticoagulation reversal, platelet transfusions for thrombocytopenia or dysfunctional platelets, observation with frequent neurologic assessments for deterioration, and controlling hypertension. The use of steroids is still controversial. Surgical management options include a twist drill hole, burr hole, and craniotomy for evacuation. For subarachnoid hemorrhage, if the patient is on anticoagulation or antiplatelet agents, reversal is prioritized. Management is typically conservative with close assessments of vitals and neurologic status. In obtunded patients, a need for ICP monitoring and external ventricular drain is common. Patients should be monitored for hydrocephalus or cerebral swelling. For intraparenchymal hemorrhage, blood pressure should be monitored to decrease the risk of further hemorrhage. The treatment depends on the etiology of the hemorrhage. Treatment options are variable and include aggressive surgical evacuation, craniectomy, catheter-based dissolution, or observation. Surgical evacuation is controversial for some forms of intraparenchymal hemorrhage. The prognosis depends on several factors, including the age of the patient, comorbidities, consumption of antiplatelets or anticoagulants, Glasgow Coma Scale score at presentation, size of pupils at presentation, location of the bleed, presence of other injuries, and time delay for surgical intervention, if needed. The IC score is clinically significant for IC. IC score is calculated based on GCS score, age, whether it is infratentorial origin, IC volume, and whether there is intraventricular hemorrhage. The mortality rate is calculated based on the IC score as shown here. The main complications associated with intracranial hemorrhage include neurological deficits, brain herniation, infarcts, rebleeds, vasospasm, seizures, and death. That's all for this video. Thank you.